and I prefer to be called Amanda, not Dr. Messina. I'm one of two bariatric surgeons here with Dr. Roslin. So when I speak to people about bariatric surgery, I'm pretty informal with them. I spend an entire hour with them in the office discussing why they reached the point that they reached, why they're wanting bariatric surgery, some of the causes of obesity. So when we think about obesity, it's not as simple as calories in, calories out. You can have 4 different people eating the same number of calories, same number of activity, and one may be obese, one may be perfect weight, and somebody else can be underweight. There are genetic components involved with how your body's metabolism works, and we clearly don't understand all the aspects of it. There are some thoughts that your environment plays a role in that. What are your exposures? How does that interfere with your digestion? How does that interfere with your biophysiology? And then obviously just simple, are you choosing to eat fried chicken, or are you choosing to eat, tomatoes and cucumbers and proteins? So all of those contribute to obesity or healthy weight or being underweight. In the bariatric world, unfortunately, we use BMI as a definition of obesity. It is certainly not perfect. This kind of gives you the ranges of obesity, morbid obesity, super obesity. But if you take somebody like Arnold Schwarzenegger, in his heyday, his BMI was 30. So he would technically fall into the category of obese. But if you looked at him in Terminator, you would never say, that man is obese. Qualifications for bariatric surgery, and this is dictated by insurance companies. There are people who have BMIs that are lower than a 35 who could very easily benefit from bariatric surgery, whether it's they've got metabolic syndrome or they've got joint disease. But unfortunately, insurance companies have set these benchmarks. So the qualifications for bariatric surgery require a BMI between 35 and 40 with comorbidities. And the comorbidities, the insurance companies also dictate, but some simple things to remember are hypertension, high cholesterol, diabetes, obstructive sleep apnea. Sometimes we can get away with joint disease. Those are kind of the main ones that we work with. Or a BMI over 40 or over, and you don't need to have comorbidity. You can have one, but you don't need to have one. So procedures, they run the gamut. That should not be highlighted. But so we have a lot of different procedures that are available for bariatric surgery. Here at Northern Westchester, there's the gastric band, which, to be honest, I don't think Mitch and I have put in a gastric band in probably close to 10 years. We certainly take out a fair number of them. The sleeve gastrectomy, gastric bypass, duodenal switch / modified duodenal switch. But then there's all sorts of other procedures that are relatively new, not necessarily covered by insurance. Gastric balloon, it's something that's space filling within the stomach. They're suturing of the inside of the stomach wall as well. So gastric bypass. So when people say you've had bariatric surgery, this is what most people think bariatric surgery is a gastric bypass. It's certainly the most well studied. It's been around for 30 to 40 years. And almost every procedure that comes out is compared to the gastric bypass. What happens is we separate the stomach into a small pouch at the top. This doesn't work, but a small pouch at the top, which is separated from the esophagus. And then the remainder of the stomach is in place. It is not altered. We then reroute the intestines. They are not removed. They are not taken out of the body, but rerouted. And what that means is that the 23 feet of intestine that you currently have, that right now you eat food, it goes through all of your intestines, your body absorbs as many nutrients as it can within that 23 feet. You don't have 23 feet to perform that absorption. So it is a restrictive procedure. The stomach is smaller, but also malabsorptive. We intentionally make it so you cannot absorb everything you eat. There's some caveats to that. The body is highly efficient at absorbing simple carbohydrates, sugars, chocolate. Bread turns directly into sugar. So if you choose to eat those types of foods, the gastric bypass does not save you from that. Sleeve gastrectomy. So I would say this is the most popular operation that patients choose, and it's growing in popularity around the country as well as internationally. It is just restrictive in nature. The stomach is made smaller. There is a portion of the stomach that is removed. It is gone, it is out of the body, never to return. We do stomach surgery and stapling over what's called a bougie. It is a long piece of plastic that goes through the mouth, down the esophagus, into the stomach, so we measure and make the stomach the same size for everyone. I use a 36 French bougie. It is the width of my thumb, okay? It is small. Your stomach is about this long, and you have a pouch about this large at the bottom. So I would say on average, people can eat up to 3 to 4 ounces of food. It's not a lot of food. The duodenal switch or modified duodenal switch, just for comparison, normal anatomy is on the left-hand side. Food goes down through your stomach, through all the intestines into the large intestine. The duodenal switch, we combine a sleeve gastrectomy. The portion of the stomach is removed. We do make that sleeve slightly larger than we would for somebody who's just having sleeve gastrectomy. And then the intestines are rerouted, similar to a gastric bypass, but the measuring is slightly different. So it's malabsorptive and restrictive. People with metabolic syndrome, high blood pressure, high cholesterol, and diabetes as a combination, or out of control diabetes with a hemoglobin A1C of 10, 12, you kind of see diabetes melt away. We don't tend to put people back on their diabetes medications right after that surgery, and we see how they equalize and figure out whether or not they need medication long term. That's the end of my slides. So I explain to patients when they come in that bariatric surgery is not a magic bullet. It's nothing exotic or special or anything that's different from having a personal trainer or somebody who makes every meal for you. It's a tool. If you don't use that tool, it's never going to work for you. 100% of people lose weight, but when you look at all statistics, it's almost 50% of people regain weight. And it's not that the surgery failed. Patients struggle with changing their habits. So if you can stick to the habits that we discuss with patients beforehand and they actually try and reinforce at every visit, they tend to sort of be long-term successful. You can have a personal trainer and pay for that personal trainer and never actually go. Or you can have somebody who brings you your meals every day and still choose to eat whatever arrives on the floor. And you will not be able to continue to be successful with it. I see patients very frequently after surgery. I think accountability is part of the success. In the beginning, it's all about what have I done for surgery, right? I'm restricting the size of the stomach, I'm changing the malabsorption. I'm operating on the stomach, I'm not operating on the brain, and there are components of hunger and fullness that have nothing to do with the size of the stomach that are all up here, and there's the donuts on the table, and I want to go grab those donuts. So I use those visits with my patients, and I see them, for a 2-week post-op, which is literally just about surgery. I see them at 3 months. At 3 months, we do a full set of nutrition labs, 6, 9, and 12 months. And then I expect to see them every 6 months for the rest of their lives. Some patients don't come back, but I do find the ones that come back, we talk almost exclusively about how are you doing with getting your 60 to 80 grams of protein a day? How are you doing with getting your 64 ounces of water a day? Where are you getting that exercise? Because your day-to-day running around on the hospital floors, your day-to-day running around in your construction job is not exercise. The weight that you achieved prior to bariatric surgery happened with all those activities, so you need to step up your game. But it's work, and it's constant work for patients. And the farther they move away from surgery, the more work it is actually for the patient. What else is it? Go ahead.
So Amanda, you said somewhere in the presentation if the patient chooses or what the patient decides on. Do they actually come to your office and say, gee doc, I would love a sleeve, a band? I mean, do they list?
Yes, absolutely. So
Really?
Before they come in to see me, we have an online seminar that patients watch, and it gives them a basic understanding of what bariatric surgery is and why bariatric surgery is an option. You need to have an understanding of what each of these is before we can have a conversation about what will be successful for a patient. If you have a BMI of 35, a duodenal switch is a pretty drastic operation. People lose between 70 and 90% of their excess body weight. And so when we talk about excess body weight, what does that mean? If you weigh 300 pounds and your ideal body weight is 200 pounds, that's 100 pounds of excess weight. 70 to 90% is 70 to 90 pounds. But you can overshoot that. Things like a duodenal switch, because there's a malabsorptive component to it, there's a greater risk of nutritional deficiencies. You can potentially end up underweight. So I kind of steer patients on the lower BMI scale not to choose something like that, but most of the time they don't come in choosing that. I would say probably most patients choose a sleeve. It feels a little less manipulative to them. There are fewer operative risks associated with it. When you talk about operative risks, bleeding, infection, injury to surrounding structures. But the stomach is cut in a sleeve, the stomach is cut in a gastric bypass, and it's cut in a duodenal switch. The difference between a gastric bypass and a duodenal switch, when compared to a sleeve, is the intestines are rerouted. You have separated them, you've put them back together. And with each anastomosis, there's a risk that it leaks. There's a risk that it strictures. So patients do come in and they say, I would like to have. And when we were just talking about this before, when you approach a BMI close to 50, a duodenal switch or a gastric bypass is kind of a better option because you're more likely to have those comorbidities disappear and achieve a healthier weight. I'm very cautious. I tell patients you're not going to be a normal weight. You're not going to reach that normal BMI of 22. It just doesn't happen with bariatric surgery. You can make it happen with other factors, but it's not the surgery doing that job for you. Scrubbing your nose. The process getting into the operating room is not a simple one because again, it's kind of dictated by the insurance companies. You have to be evaluated by a psychologist. The vast majority of patients though, they're not in a psychological position where we would say, no, you can't have surgery because you're not going to make the right choices after. You meet with Brianna. Brianna is essential. Before surgery, she meets with everybody. The day after surgery, she meets with everybody. And then she runs some support groups, which are incredible for patients. Patients will have met with me, have to have watched the seminar, and then 6 months supervised weight loss. The 6 months supervised weight loss is, again, it's almost like a benchmark for most patients to achieve. Some patients need a little bit more dedication and focus beforehand, and they may see Brianna beforehand or see their primary care physicians once a month for 6 months. So they demonstrate a concerted effort towards trying to lose weight. Most people don't step into my office having never tried a diet. Most people have checked off every line. I've done Weight Watchers, Nutrisystem, Atkins.
Diets that I've never even heard of.
Yeah, there's something.
And they're educating me about things they've tried.
Right, right. I think it's, go ahead.
More, do you see for bariatric surgery more male, more female, and who is usually most successful post-op with adhering to what needs to be done?
Yeah. So vast majority of my patients are female. A handful of men, and it's usually spurred on by they can't necessarily do their job functions anymore. So it'll be the construction worker or the police officer. I have a young man who wants to enter the military and he was told he couldn't enter the military at the BMI that he was, but they are definitely fewer men than there are women. That's not to say there aren't just as many men who are released, it's just who chooses to go this route. Success. Success is hard to predict, but we were talking about focus and patients really making it part of their daily decision making. I tell everybody, write everything down. The second you have to write down that you had that donut hole as you walk down the hallway is the second you stop doing it. The support groups. Now, the support groups, some people love to be in a group and talk about what's working for them and not working for them, and others don't like being in a large group setting, but they are available. Exercise, right? You're turning over a new leaf. You're trying to change whether it's your physicality, I can't fit into an airplane seat, or my mom died of diabetes at 65, I don't want to be in that same boat. You have to keep that in mind daily. You can't let that slip. There are roadblocks for everyone. Nobody is perfect. You're going to choose to have 2 slices of bread at dinner one night, but we would prefer if you didn't, but it's going to happen. So the people who I think the most successful are the ones who really, it's part of their daily routine. And it gets harder, again, as you move farther away from surgery.
So I was reading your slides. I see that it's also possible in adolescence. How young is young? How young will you do this?
So it's really a conversation between, obviously, the parents, because the parents sign a consent, but also the child has to be of ability to make a sound decision. I would say that's probably starts somewhere around 16. Personally, I think a 12-year-old really has no comprehension of the long-term implication of their weight. But I think by the time you're 16 in high school, you understand what the physical limitations are with your weight, but also your parents may have some comorbidities that they're struggling with as well. But it is a much bigger decision, I almost think, as a 16-year-old to choose to do that than at 22. But there's not a hard and fast rule. I think we're approved to do down to 13 here.
Yeah. Does anybody from the OR know how much weight do our OR tables hold? What's our maximum?
The OR table holds 1,000 pounds.
Oh.
So that's not actually our limitation. Our limitation is our CAT scanner.
Right.
So we give patients a weight of 450 pounds as a maximum. If they are exceeding that, the risk is that they won't fit into the tube. And obviously, if you are having a post-op complication, they need to do a CAT scan as opposed to going to the OR. You have to fit in the CAT scanner.
I think there's a limit on the beds too.
It is. I think it's 1,000 pounds.
Is it?
Yeah.
Beds?
The bed's can sustain a large amount of weight.
Those bariatric beds are every.
The OR beds, bariatric beds. But I don't know the floor beds.
That's what I was thinking, the floor beds. I don't think they hold 1,000 pounds. I don't know.
The wheelchairs, I think, are 450.
So there may be some other limitations, but the CAT scanner is definitely for a surgeon a limitation. Other questions?
Do you always do a cholecystectomy for the duodenal switch?
I do not. So bariatric surgery, high risk of developing gallstones. The theory is the rapid weight loss leads to a little bit of stasis of the bile, which increases your risk of having gallstones. Or you may have gallstones before and you just don't know it. I don't routinely take out the gallbladder. I view every additional operation or procedure you do on the patient increases the risk, right? If I do an appendectomy at the same time as doing cholecystectomy, what if that appendectomy state of line leaks? So I kind of limit it. If somebody's coming in and they already have gallbladder disease and we know that's a problem, then yes, I would take out the gallbladder, but I do not routinely take out the gallbladder. You used to.
How about childbearing after bariatric surgery?
So we have had some recent pregnancies. So I tell patients that we would prefer if you wait 18 months after surgery, minimum 12. Your vitamin levels change dramatically, and I'm sure you'll touch upon this, but your vitamin levels, we do check at 3 months and I check them every year. Babies are like parasites, right? So if you're not nutritionally sound going into it and they're sucking everything away, there's a risk that the baby doesn't get what they need. So I want them to be at a healthy weight, and pregnancy or lack of being able to get pregnant is one of the reasons why people choose to have bariatric surgery. We want them to be in a good place. We want to make sure they've got good habits. And 6 months in, you may not have good habits yet, and you certainly don't know where you're going to be nutritionally. The surgery's in the operating room, so I tell people it takes about 90 minutes for a sleeve gastrectomy for surgery. A fair amount of that time is actually getting the patient situated on the OR table, getting them off to sleep, positioning them. They're in a split leg table. The surgery itself, first sleeve, is about 45 minutes, and then you have to do everything in reverse, right? They are higher risk in terms of putting to sleep because of the soft tissue on their necks. But the anesthesiologists are phenomenal here. For a duodenal switch, it's about 2 hours, 2.5 hours in the operating room. Gastric bypass is about the same, although to be honest, I haven't done very many gastric bypasses yet. It's just not frequently chosen.
About what percentage needs a hiatal hernia repair as well?
I would say it's probably 10 to 15% that comes in with symptoms of reflux that I then do a test to see if they actually have a hiatal hernia. So if somebody has reflux before surgery, the sleeve gastrectomy is a high pressure system. The pylorus at the bottom of the stomach is very strong, whereas at the GE junction, that sphincter is terrible and very weak. So if you have reflux symptoms before, you have a hiatal hernia before, and you make a system that does not stretch, because the sleeve does not stretch, then reflux symptoms get worse. So you want to confirm beforehand if there's a hiatal hernia.
Are you ever surprised by one?
Rarely. Usually you know because people are symptomatic. There are times when I think there's a hiatal hernia or they've had an upper GI that shows one and I go in and the hiatus is fused, in which case there's nothing to fix.
Do you feel that they're in more pain after the surgery if they've had that repair?
They feel more pressure in their chest.
Okay.
So because you've dissected at the crura, more air tracks up into the chest and so they feel it more here. A lot of patients complain they have the shoulder pain after the surgery. And obviously they have surgical pain, but they have usually it's right shoulder pain, but they'll feel it more like right underneath their sternum. Yeah. I don't know why, because they're not really on the left, but you feel it all the way. Perioperatively, I mean, some of you were upstairs on the floor, but perioperatively, one of the biggest things that I tell the patients is going to happen to them is that they're going to be made to walk. And I tell them all that you're all drill sergeants and you're not being mean and you're not trying to do them ill will. We know that you've had surgery, we know you're tired, but walking is essentially to prevent DVTs because that can be catastrophic. So I do try and do that in your favor. Other questions? Oh, you can.
Thank you.
Yeah.
But we're at a bariatric lecture, nobody's going to eat.
I'm Brianna Farrand. I'm the bariatric dietitian, so I work with both Dr. Messina and Dr. Roslin. So just to give you a quick overview kind of what I do. So I meet with each patient at least 4 times, once preoperatively, and that's a longer consult, like a full hour that I spend with them. Once post-operatively while they're here inpatient, and then at least twice as outpatients, and then usually longer than that as well. So I help prepare them for surgery in that first pre-op consult. We really spend a lot of time talking about what does the diet look like afterwards, what are the lifestyle changes that are needed, because as Amanda was saying, if they're not fully committed to that process, I think sometimes they do come in thinking that surgery is going to fix this problem. They have to really understand that the surgery is the first step, but then I tell them every decision that they make every day the rest of their lives is what impacts their weight and how much weight they lose. So I respond to their phone calls. They're often calling with lots of questions. Pre-operatively, what kind of vitamins do I need? Post-operatively, I'm nauseous or I'm having trouble getting things down, like what do I do? So I spend a lot of time with them on the phone. I do review their labs that Amanda and Straw, at 3 months and 12 months post-operatively and annually for deficiencies, and call them and talk to them about what kind of supplements they would need to fix those issues. I do facilitate the support group, so we meet twice a month in person here in the conference rooms. We also have a Facebook page, so we're trying to expand the number of ways and touch points for patients to get in touch with me and with each other and have that social and emotional support, which we know is so important after surgery. And then of course I collaborate with the docs and the PA and everything. So preoperatively, my main goal of working with them for that first visit, or if we have a few visits preoperatively, is to really try to help optimize their health status before surgery. So Amanda and I will talk about, the fact that their A1C is elevated, and she's thinking, of course, about their operative risk. When they're on the table, what's going to increase their operative risk and perioperative risk. And I'm starting to work on encouraging those behavior changes. So, there was a study that showed that even up to as little as 8% of weight loss preoperatively was correlated with a significant increase in weight loss postoperatively 1 year post-op. So you'd think that like by 1 year, even if you had lost any weight beforehand, 1 year gives you so much time to work on that weight loss afterwards that people could equalize. But someone who had lost even 8% beforehand was still at a higher weight loss a year post-operatively. So I talked to them about that, because I think sometimes they think too that, well, I'm already here, I'm already having surgery, you know, going out, have one last supper or many last suppers, and it's like, no, we need to start now, it's game time, we need to start making changes now. And then a couple other smaller things like trying the protein shakes, making sure that they're ready for after surgery. There are supplies that I try to encourage them to have in their homes, things like baby utensils because they help eat more slowly, obviously measuring cups, maybe a food scale, start getting used to logging food in MyFitnessPal or this other app, Bariatric, or using a food journal. So really trying to prepare them for what they're going to be, working on afterwards. When I think about the post-op nutrition, there's kind of like 3 pillars that I think about. So there's true nutrition in terms of what they eat, their vitamin and nutrient status. There's tolerance. So now that they've just had surgery, what kinds of foods, what textures can they, chew and swallow and feel comfortable eating? And then there's other lifestyle behaviors like sleep and exercise. So those are kind of the 3 things that I'm always thinking about when I meet with our patients post-op. So the post-op diet progression, which you guys are familiar with, definitely the stage 1, the clear liquids, this is really an issue of tolerance. So they've just had GI surgery, their stomach's smaller, maybe their intestines have been rerouted. It's a texture progression from basically liquids to mushy foods to soft solid food and then back to regular texture. The kind of timeline that I have listed here is the date that they start that diet phase. So they start the clears, post-op day 0 while they're here inpatient. They're on clears just for the first day or 2 while they're in the hospital. As soon as they go home, which is usually post-op day 2, maybe post-op day 3, they start on the full liquids, so the protein shakes and the yogurt, as soon as they get home. They're following the full liquids for about 2 or 3 weeks. And then they're starting thin purees around week 4, so that would be mushy foods like cottage cheese or pureed chicken soup or scrambled eggs, that kind of texture. About 2 weeks later, they're usually ready to progress to soft foods, so that would be things like chili or baked fish or soft ground meats, what else? And then as well as soft cooked vegetables and ripe fruit, so they're starting to incorporate more whole foods at that point. And usually we say around week 8 or week 9, so about 2 months after surgery, they're really kind of considered unrestricted in terms of their texture. That's not a green light to go back to eating like pizza, pasta, all that stuff. It's about the texture. So it's like, hey, if you didn't try broccoli yet because it's very crunchy, you could start to try it. Or if you hadn't had an apple yet, you could start to try that. But we're both working with every patient more individually because this is not like a hard and fast timeline, but it's just kind of an idea for you. So in terms of their nutrition goals, they're a little bit differentiated based on which surgery they had. So for the sleeve surgery, the goal is a minimum of 60 grams of protein per day and a minimum of 64 ounces of clear fluid. So I just wanted to give you an idea of what 60 grams of protein looks like in terms of food. I think sometimes patients are like, 60 grams, but that's a lot of protein. It's like, well, but you're actually eating more than that now. So it's less than you're eating now. It's just more of a focus on protein foods and cutting out some of those other foods that are higher in carbohydrates. So that would be like a 4-ounce chicken breast, which is a small chicken breast, a cup of Greek yogurt, 2 hard-boiled eggs, and a half a cup of black beans. Not that much, really.
But they can't fit that much in at a time.
No.
Correct. Yes. So that's
all day.
That's over
all
the course.
day.
Yes, thank you. That's over the course of a whole day. And I wanted to make the point that's not what they're eating right when they go home. They're obviously following that texture progression. They're on, the first 2 weeks they're having full liquids, so it might be 3 protein shakes and a yogurt. But this would be like an unrestricted day.
Do they have like coffee and water, like unrestricted?
Yes. I mean, we encourage no liquid for half an hour before or after their meal. But other than that, yes, they're unrestricted, but they're going to feel restricted in terms of how much volume they liquid I want to do.
Right, I was gonna say, if you eat your protein first, and then I tell them, your fruits and vegetables. But again, you can't then put water on top of that. It's just not gonna go down. It will come back up. And they usually make that mistake once.
And it's really interesting. I mean, I hear, they tell me, they're like, I hope you don't mind. Like, no, I don't mind if we talk about it. But they'll be like, well, it was just the water that came up. I'm like, well, that was the part that didn't fit. That was what didn't fit. So it's literally that specific. So it's kind of interesting. I think it's a really teachable moment for them as like, oh, okay, like that's why they said to wait half an hour with the liquid. So with the duodenal switch or the gastric bypass, the protein goal is higher. That's the main difference. So we encourage at least 80 grams of protein, 80 to 100 grams of protein a day. Protein goal is higher because those procedures are malabsorptive. So in other words, the patient's not absorbing all the protein that they're eating. So we need to start at a higher threshold. But that would be, in terms of our food examples, that would be just the addition of like 3 ounces of salmon. Again, this is the full day. So it's really not, it's not a lot of food. It's really not a lot of food. So to go kind of into a little bit more detail, what I was saying before with those 3 pillars of their nutrition post-op, there's a lot more that goes into it. So, in terms of their nutrition, certainly their protein and their fluid, but they're taking chewable or liquid vitamins every day. There are a couple different reasons why they need the supplements, but even with a sleeve that's not malabsorptive, the volume of food that they're eating is so much less. So it just makes it hard for them to achieve their RDIs and their RDAs in terms of how the nutrients that they need every day. So multivitamin, but a chewable multivitamin. And then of course with the malabsorptive procedures, the DS and the bypass, there are additional supplements that are needed because we know they're not absorbing all of the nutrients from what they're eating. A lot of what goes into their nutrition are their food choices, behavior change. We all make something like 200 decisions every day about what we eat. What we eat, how we eat, when we eat, how fast we eat. So those are all things that come into more focus after surgery that really impact their weight loss and their weight maintenance. And their meal pattern is something we talk about a lot. So because they can no longer fit a large meal at one time into their stomach, it's imperative that they eat every 4 hours or so during the day. So I have a lot of patients preoperatively who, this is a very typical pattern. Maybe they eat something for breakfast, something very small. They go to work, they're very busy at work. I know we're all very busy at work, but they go all day without eating, they're in meetings, whatever, they're commuting, they're traveling, no time to eat lunch or a snack. And then they come home and they're famished and they eat a huge meal for dinner, or it's a normal sized meal with the family or whatever, but then we're grazing after dinner for hours before going to bed. So I tell them that pattern really has to change. Like now that you're having this surgery, you're really committing to making changes, one of which is eating more frequently and kind of watching the clock because you're not really going to feel hungry for quite a while after surgery. So it's interesting when you think about if you didn't feel hungry, you could go a long time without eating. I mean, right, like your feeling of needing food or your stomach feeling empty, that's what drives you to eat. So it's challenging afterwards, and I'm often reminding them, like, hey, I know you don't feel hungry, but it's been 3 hours, it's been 4 hours, you have to get into the pattern of eating more often.
I tell a lot of patients to set an alarm. They'll say, I wasn't hungry, I didn't eat this.
Right.
But you have to set that alarm. You're not hitting the goals that you need to hit. And long term, that can have some real
Medications, yeah. I think a lot of patients too, I know because they tell me that I think not feeling hungry and not being a slave to like the next meal or preparing food and not being a slave to always feeling hungry is pretty liberating for a lot of them. So when they're not feeling hungry afterwards and they can then engage in their work or their other activities and not have to think about eating is like enjoyable, but then we can go down the path of them not eating enough and not meeting their protein needs, so that obviously has long-term ramifications. Yeah.
Brianna, what kind of protein shakes do you recommend? Would you give them what you want them to have?
We don't distribute or sell any products, but we do give them a list of recommendations. They're all whey protein powders, so whey is the form of protein from milk primarily, and we recommend that they use a high protein, low sugar. Whey powder, and then mix it with either milk, low fat milk or water. But I do give them specific brand names and encourage them to try them ahead of time.
And don't buy a lifetime supply because your taste buds do change.
Yeah, it's here.
So I'm kind of confused if they're going to gain weight because they don't choose the correct foods, such as they're eating donuts instead of the chicken or whatever. I don't understand how they can gain so much weight back.
It's slow over time. It's not like they regain all that weight in the same period that they've lost it. It's a steady increase. The behaviors are the hardest thing to change. right? We've physically made the stomach smaller, and yes, it does stretch to some degree, but the behavioral changes are sort of ingrained and start at a young age, right? You know, a lot of people can say, I'm skinny until I had my 2 kids and then I gained all my weight. But there are plenty of people who come in and say, I was fat when I was in 4th grade. I mean, I hear that repeatedly, and that behavior is really hard, which is why Brianna's like, you have to set your alarm, you have to pay attention, and the ones who are the most successful write everything down.
And that grazing pattern that we were talking about at nighttime, that a lot of people have a bad habit with that, you can still do that after surgery. You know, you're eating small amounts of food over many hours. You can still do that. So, you know, especially if it's the wrong food, if it's high calorie stuff, if it's ice cream, things that slide down nice and easily and don't make you feel that full, you can, gain the weight back incrementally. So moving to the tolerance issue, that's something that I work with them quite a bit on afterwards too, because it's I tell them it's like rediscovering, like you have this new stomach and you're rediscovering how it works, how foods make you feel. You know, moving through the texture progression, the rule of 30 is not drinking 30 minutes before or after the meal. We really emphasize the importance of eating slowly, chewing everything very well, because your stomach, which could, you know, prior to surgery, do a lot of the mechanical work of digestion, now is much smaller, and you know, you really need to really start that digestive process in your mouth with extra chewing. And of course, we talk about portion control, 4 ounces being the maximum at any one meal. With more solid foods, as they're just starting out, they may only be able to eat 2 ounces, and that might be it. So really paying attention to how you feel when you're eating, stopping when you're full, that kind of thing.
And the sensation of full is different, right? Right now, your stomach is a big muscle and it will stretch. You could eat 4 slices of pizza, so you should choose, and it will go down and it will generally stay down. And when the stomach is tiny, it does not stretch like that. And your stomach actually sits much higher in your body than you think. Like we all think your stomach's down here. It's actually sitting kind of right behind your breastbone. So they feel full here. And it can be a pain, it can be it just feels weird, I feel bubbles, whatever it may be, but their sensation of full and the signal to stop is different. And it's usually the first episode they eat too much that they realize where that point is from.
And the other interesting thing about that is a lot of times before surgery, not every patient, but a lot of times, they're used to eating to the point of feeling stuffed or uncomfortable. And they don't even really realize that's the case, I think, sometimes. And then after surgery, we're talking about it and they're learning like what it's like to feel full or satiated but not stuffed. It's a big difference when you think about it.
6 West. Your attention please, code Bray 6 West. Your attention please, code Bray 6 West.
So that's a big change afterwards as well. And then I also work with them, we talk about any GI issues they're having, we talk about the frequency of their bowel habits. With the malabsorptive procedures, that can be a clue for me as to what they're eating or what they're not eating. If they've got like 6 or 8 or 9 bowel movements a day after the duodenal switch, that can be a problem. Are you eating a lot of high-fat foods that aren't being absorbed and therefore are coming out? We talk about exercise, we talk about adequate sleep, we talk about psych and emotional support. You know, like Amanda said, for some people that means coming to the support group, and that can be that emotional support for them. If they have a close friend or a family member who had bariatric surgery, then that maybe means more of a connection with that person. Maybe it means professional help, because a lot of them are smart to realize that the behaviors that drove them to eat and to gain the weight in the first place are not going to be solved by the surgery, and therefore like a complementary psychotherapy would be really, really beneficial. So we can just figure that out.
There's also a fair amount of marital discord that happens once the weight loss has happened. There's something to do with behavior and the relationship that you have with your spouse that existed at whatever weight creates a dynamic that when patients lose the weight, that dynamic changes. So I hear it all the time.
Did the families participate in the psychological side?
Psychological evaluation?
Yeah, they consider them just
No, I mean, they are asked, the patients are asked, what kind of support do you have? And the vast majority of patients, their spouse is supportive of it. but nobody understands what the changes are until the changes have happened. And for a lot of people, they gain a confidence that they didn't have prior, and that changes a relationship. I have a fair number of, people come in at 9 months, they're like, I can't stand my husband, I don't know what to do. And I spend 30 minutes discussing that, nothing to do with like what you're eating, what you're exercising, we're discussing that because it is such a big change. Your dedication to, I'm going to the gym as opposed to doing whatever the other activities were, or they're more focused on themselves. Right, it's just very different. So the psychological support is definitively necessary.
And as we were saying, the vast majority of the patients are women, and oftentimes, as we know, unfortunately, gender stereotypes and all that stuff, the wife, the mother, the woman is the one, grocery shopping and meal planning and cooking the meals. And so after they've had surgery and they're choosing to eat different foods, that obviously bleeds over into the family and what the family has access to. So that can be an issue too. Yeah. So just a couple more slides. So things I thought, I was trying to think about what might be helpful for you guys, when we're immediately post-op with the patients. So common misperceptions that the patients have. I'll call them a few days after they're home, like 4 days post-op, and they're like, oh, I thought I was supposed to be on clear liquids for a week. Not because of what you're telling them, but because other surgery centers have different requirements, they read things online. Despite all the paperwork I give them and the number of times we talk, they forget. So you can help me reinforce the fact that they start on their protein shakes and yogurt as soon as they get home. So as soon as post-op day 2, whenever they're going home. Yeah.
Sorry to interrupt,
No.
but a lot of them go home on post-op day 1.
I send them home the day after.
Oh, I'm sorry, post-op day 1, you're right.
So
you're
that's
right.
okay?
Yeah,
You can tell
yes,
them they can
yes,
have their yogurt
yes,
when they go
yes,
home?
Yes, oftentimes, you're right, I'm sorry, I've been saying 2 or 3, but it's usually 1 or 2, you're right. So yes, as soon as they get home on post-op day 1 that evening, or if it's post-op day 2.
Does carbonation bother them?
Yes.
Yes.
They say no carbonation, no chewing gum, no straws, because of the excess air that they're swallowing. Yeah.
And how long for no caffeine?
I tell them 4 months.
4 months?
I tell them 4 months. I tell them 4 months no alcohol, 4 months no caffeine. I tell everybody when they come to see me, I said you need to quit drinking caffeine well before you get to the hospital, because the caffeine headache is worse than cervical pain.
Yes.
Yeah, we've talked about that, right?
Smoking. Okay, so smoking. I check nicotine metabolites, and I will cancel surgery if they have not quit smoking. And I'm very clear with patients. It's not something that everybody universally does, but I
love that you do, because I think it's so good.
It impedes wound healing. You're turning over a new leaf and trying to make yourself healthier. There's not a single study that proves that smoking is good for your health. So they have to quit smoking. There are people who go back, and I know that happens, but I give them the opportunity to be in the best physical shape they can be for surgery, because it is a risky surgery.
And I'm just going to say about that. They said the patient's saying I've got chest pain every time I drink. They're probably drinking too fast. So I know that's something that you guys know, and I try to, because I try to reinforce to them, because they think they're drinking slowly compared to how they used to drink. It is much slower, but it still may not be slow enough. So really getting them to take very small sips. That's why while they're here post-op, we tell them just that 1 ounce in 15 minutes. So really, and not to take it like a shot, but to take the whole 15 minutes to drink it. So that's something we run into a lot. And then also I hear, patients or family members or support people thinking that, if there's any sugar in anything they're drinking or in their yogurt, that it's going to damage the surgery or hurt them. The sugar piece is not about tolerance, it's not about the surgery, unless it's a gastric bypass, that's a little bit of a different story with dumping syndrome. But for the most part, sugar is not going to hurt them. It's just from the nutrition, standpoint, we're trying to eliminate added sugar, help with the weight loss, get rid of some of those cravings, and kind of change those kind of addictions to those high sugar foods. So that's really what we're going for with the low sugar or no sugar. And then I just wanted to end on something that I thought was interesting, that a lot of patients coming in, they've been thinking about surgery for a long time, and they've made the decision, but maybe they haven't told, maybe they've told their spouse but no one else, or they maybe even haven't told their spouse yet, or I'm not telling anyone at work, or I've got friends, I'm not telling them, because a lot of other people have this misperception that surgery is the easy way out. We hear that all the time.
Yeah, it is so not easy.
It's not easy at all. So when you think about, I was thinking what's my list? I'm like, oh my gosh, there's even more things than I had thought in terms of what is not easy about having the surgery. The lifestyle changes alone are huge. because we all know we have a lot of habits around, how we eat. And a lot of, when you start thinking about your social relationships that revolve around going out to dinner or having drinks and eating in some way, all that has to change, as well as taste changes, maybe dealing with dumping syndrome, lactose intolerance that we see frequently after surgery, hair loss as a result of the rapid weight loss, not permanent hair loss, but still, that's not fun.
Dramatic.
Yep. Hormonal shifts, mood changes, excess skin potentially when you've lost a dramatic amount of weight. Potentially you've got excess skin hanging after a year and you're either thinking about a skin removal surgery or, maybe it's not quite that dramatic, but the excess skin can cause rashes and difficulty with physical activity. So there's a lot that they're dealing with after surgery. So it's like so painful when I hear them say that someone told them that they were taking the easy way out, or they're not telling anyone because that's what they know they're going to hear. That's really challenging. So we talk about all the reasons why it's not easy and why they have to be committed to doing all these things.
With the hormonal shifts, do you see changes, do the patients see changes in menstrual cycles? I know you also mentioned you'd rather they not childbear immediately. Do you recommend some sort of...
So I do recommend birth control. Because you don't want to have an unexpected pregnancy. One, it can kind of derail your weight loss because you do gain weight during pregnancy. Two, we talked about the vitamin changes are definitely dramatic and can shift, and all of a sudden you can be low in vitamin A. We have a patient who's good now, and that's essential for healthy eyes in utero and also just in the adult. So definitely, I recommend birth control. There are patients who come in and they have PCOS and they can't get pregnant, and part of that is the obesity, and then they lose the weight and they can get pregnant. I'm very clear with them that they should not make the assumption that because they couldn't get pregnant before surgery, they're not going to get pregnant after. I love the IUD, and I actually think it works very well for most patients. There's nothing else that they need to remember when they're trying to remember everything else.
And Brianna, this time of year, between Halloween, Thanksgiving, and all the holidays coming up, it's a minefield. How do you help them navigate that minefield? Because everywhere you go, even at work, everybody has a pumpkin with candy in it on the unit.
Yeah. Well, one thing that we talk about, I encourage them to come to support group as often as they can because they really help each other and they support each other. And maybe you were having a bad month, but someone else was having a good month, and you can share. So I just encourage that engagement constantly with the program and with the other patients. But one thing that came up recently at support group that kind of was eye-opening to me was patients, talking and having the realization. One patient had the realization that her always thin coworker, she was watching her eat lunch and take the bread off of her sandwich, she took the top slice of bread off of her sandwich, and she was kind of observing her coworker do this. And she's always been thin, she'd never had bariatric surgery, and she kind of had the realization that everyone does things to manage their weight. These are things that everyone who is a normal weight and wants to maintain it, pays some attention to. Maybe doesn't struggle with quite as much, but is paying attention to these things. So I think that is at least a helpful realization that, the holidays are hard for everyone in terms of food being, lots of food and unhealthy food being all over, and that it's something that you just have to kind of make your own personal rules maybe, and I've got the party coming up on Thursday, so I'm not going out to eat on Tuesday, whatever. I try to encourage them to make their own rules, set their own goals, to kind of deal with those things. But I think realizing that everyone deals with that stuff is at least helpful.
The holidays tend to have a fair amount of protein with each meal too. You think about Thanksgiving, and there's a lot of vegetables. So there are some very good choices, and it's not to say you can't have some of that gravy on top of stuff as well. Just the quantity that you eat and being thoughtful of when you're full has to come into play, right? For Christmas Eve, I make filet mignon. It's the perfect thing to have if you're enough months out from surgery to have as your meal, and it tastes delicious, and there's no reason why you can't have it.
And even having, I tell them to try to think about, on Thanksgiving, what's the one thing you really look forward to? Whether or not it's the protein, I tell them, what's the one thing? Have a small portion of that.
A little bit of apple pie.
Yeah, and then move on with your life. And realize that the holidays are not 3 months long, they're one day each, right? And so enjoy something on that one day, but don't make it a 3-month splurge. So we do talk about kind of more concrete strategies like that too. Other questions?
For those people with lactose intolerance, so how about the whey protein for the shake? Does it give them gas or something?
It can be problematic. Did you want to? You can get a lactose-free whey powder. So there are certain brands like Isopure which are certified lactose-free. So that would be like the first option perhaps for someone like that. But sometimes we'll just say, you know, okay, there is a lot of dairy after surgery between the whey powder, maybe skim milk, the yogurt. So sometimes, yep. So sometimes we have to say, okay, the lactose is not working for you right now. Let's just start doing like pureed chicken soup, things like that. We could do soy protein powder. We can do lactated milk. There's other things that we can start to try to avoid that.
You mentioned that most patients, well, they all meet with you before, and most of them have been on every diet under the sun. So when you're encouraging them to lose that weight pre-operatively, what do you recommend? How do you recommend that they eat?
Good question, yeah. So a lot of them are coming to me looking for me to like prescribe the next diet. Like, give me a paper and I can follow it. And a lot of them are like really good diet followers. Like they know how to do it, they've done it, you know, a lot. But I tell them like that's not what this is about. These are about small changes. So after hearing like what their typical diet is like and what their day is like or their work schedule or what they do, I usually recommend like 2 behavior changes. So it's like, hey, you're going to eat lunch every day. That'll be like one thing to work on. And you know, maybe the second thing would be like at dinner, avoid the high carb foods. So get rid of the pasta, the bread, the rice, the potato at dinner, and just focus on protein and lean veggies. But I try to give them 2 very like specific things to start working on. And it's not like follow the paleo diet, but it's like start making these small changes and realize that those are going to have an impact long term.
I also talk about, you know, if you come in and you weigh 240 pounds, or let's use nice easy numbers, you weigh 200 pounds, right, you're 100 pounds overweight. With a sleeve gastrectomy, you're going to lose about 60% of your excess weight, that's 60 pounds. If you gain 10 pounds and you weigh 210 pounds going to the operating room, well, that extra 10 pounds, you'll lose 6 of that, but you're not going to lose that additional 4. If we're working on averages, right? Mm-hmm. So if you lose 10, then you're going to weigh less than if you stay exactly where you are. So I try and make it very concrete, and then I talk about, you're not, you know, the next time you decide to have a second piece of lasagna, think about where that lasagna is going. It means that you're going to be higher starting in the operating room, less healthy in the operating room, and therefore maybe not achieve the goals that you'd like to achieve after. Mm-hmm. You give them the you know, that part, but I break it down to the numbers.
I think that's helpful. Yeah, because a lot of them have been on every diet, so it does feel a little bit hard or unfair to be like, you have to cut all carbs and start following this very specific diet. I mean, I try to start emphasizing the kinds of changes that we're going to work on afterwards and start just working on them now. But try to get them to like earnestly start working on them rather than like have the Last Supper kind of mentality where it's like, well, I'm not going to be able to eat lasagna for 2 months afterwards, so I better have it every night now. Yeah, that's challenging.
Yeah.
Any other questions?
Any further questions? Any cases you've seen that didn't make sense or issues that came up?
Do you see a significant amount of weight loss in the first 8 weeks?
There's definitely people lose very quickly in the beginning,
right,
and then you start to slow down.
Yeah.
And depending on which procedure you've had, then you can sort of see yourself bottom out at 6 months.
Yeah.
With the duodenal switch, you can be closer to a year. And then you'll see fluctuations up, down, 2 pounds. But yeah, it's really quick in the beginning.
Yeah, because you know what they can eat is.
It's a big change.
Yeah. I have a question about like what you do pre-op, you know, when you meet with people, because it's over and over I hear, no one told me that it was going to be this bad.
Okay, so
You know, it
I
hurts.
brought an example of the folder that, and you're welcome to pass this around, of the folder that we give to patients. I literally spend an hour myself talking to them, and then my nurse goes in and then they speak with Brianna. So it's a lot of information to take in, and I think that you only hear part of what's being told to you. I try to encourage people to come with a loved one or somebody who's going to be with them, because again, their second set of ears and what they hear is going to be different. But all of these rules are written down and are explained to them. And I never say it's easy. I actually tell them it's really hard.
No, but I mean the pain itself. Because I do know at one
I tell them
point-
all, it's surgery, there's pain. No, there's no lying about pain.
No, I think you do. I know Dr. Roslin has told his patients, it's like getting your teeth cleaned.
I don't think Dr. Roslin's had surgery. So I've had my appendix out and I've had 2 C-sections. So I tell everyone, I'm like, listen, if there is pain, and I'd love to tell you there's no pain, I tell everybody you need to take a week off from work. If you do a physical labor job, you're a nurse, you're a construction, you're a police officer, you do anything that requires physical lifting, then you may need 6 weeks off from work or modified job. If you can take a second week off, that second week is when you get your legs underneath you. That's when you're like, okay, this is how I plan my meals. I'm not concerned so much about the discomfort in my belly and am I drinking enough. But that's when I plan my meals of, all right, I'm going to get up in the morning and I'm going to start drinking some water, and then 30 minutes later I'm going to have my protein shake, and then you plan your day. Because going back to work is a huge jolt. It's all of a sudden, I don't have time to eat. I've got patients on the floor. You have to figure out how to plan. So that second week is really good for that. But yeah, there's pain. Anything you think we should be telling the patients that we're not telling them? Besides pain, we can emphasize that more.
That's really the biggest complaint, that they're shocked at how they feel. Because I've said to many people, I've never had a patient say, I'm sorry I did this. They're all happy they did it. However, the first day or 2, they are saying that.
I tell patients you'll feel like you were hit by a truck.
Okay, that's pretty.
You do, and you don't necessarily for the first day, but the second day, you really feel it. The first day, I'm kind of.
I know you said you'll cancel surgery based on like smoking, if they're still smoking. What do you find is like another big, like is there any other barriers to where you won't perform?
That's really the only one. I mean, if they meet with the psychologist, and the psychologist is
As
really
long as
very
they follow the
concerned.
steps and they're not too big, then
Right. Because most people don't walk into this on a whim. They've thought about it for a year or 2 years, and they've finally reached a point where I can't do it myself, or I can't get on the floor with my grandkids. My mom just had it. Whatever it may be, like they usually hit a point where they're like, okay, this is it. I'm ready to do it. It's not that they haven't tried before. And again, I tell them it's not special. It just we know it
because I think
works.
we're starting to see a lot more comorbidities, like a lot more people coming in who use walkers at baseline or canes at baseline, and we're starting to get bariatric surgeries. That's why I was wondering
if they're immobile. So like if they're in a wheelchair, I won't do it on somebody who's wheelchair bound.
Gotcha.
But we don't really see much of it.
Well, thank you both very, very much. This was very helpful.